All right. So wanted to start with our website traffic update. As of just a couple of, about a week or so ago, Atlas has been visited over 340,000 times since the launch, which occurred back in July of 2020. So incredibly excited about that milestone. And the graph here shows since September of 2020, which is when we started tracking this data, how many sessions, assessment completions, total searches, and total facility views have occurred. So again, if you think back to where we were back in September of 2020, very much in the middle of COVID, not a lot of visits were happening in many treatment facilities. And so we were still working through, outreaching to our state partners who were, working together in concert regarding promotion. And so as you can see over the last several months in particular, starting to see some increase in sessions, assessment completions as well. And you might see a rather large bump in July. So if you recall, we added 4 new states to Atlas: Pennsylvania, New Jersey, Oklahoma, and New Jersey, Oklahoma, Pennsylvania, Florida, sorry. So that's why you see the bump there. And so as we continue to move on into September and beyond, we'll continue to update this data here as well. So I wanted to also provide an update in terms of where we are with our project timeline. And so right now, in September of 2022, we just started our open enrollment period, which kicked off on September 7th. So many of you should have received emails regarding the opportunity to submit data to Atlas. Now, if you already have, and there's nothing, no updates, there are no updates in terms of your services and types of, treatment that you provide, no further action is required. And at the same time, if there are updates or you did not submit data previously, this is your opportunity to do so. So between now and December 30th, as when the open enrollment period will continue through. And then we are also including California for the first time. So incredibly excited about that work. And so we have a dedicated team out there who's doing some phenomenal work, working with all of our stakeholders in California and all the providers as well. So really excited about the work that we're doing in California and in all of our states. But as we continue to move on into early next year, can't believe it's already 2023. So in early January, we'll be doing our data analysis and validation process. So if you recall, once the surveys are completed, we conduct our internal validation process to make sure that all the information is following our terms of service, that all the attestations are there, and that it takes a little bit of time. And as we go on to March of next year, we'll conduct our provider preview period. So as many of you know, that is the provider's opportunity to look at the information that they submitted via the survey and ensure that there are no updates that need to be had. And then if there are, of course, we are happy to address any changes that were or that need to be made. And then in April, the Atlas website will launch in California for the first time, and then the data will be refreshed in all of our other states where we received additional information. So just a little bit of an update in terms of where we're going over the next several months. So also wanted to discuss upcoming roundtables and CQI webinar dates while we have the group together here today. So our next session will be on October 6th at 1 p.m. Eastern time. And we'll start to get into our provider portal data. I know we've talked a lot about that. Many of you may have logged into your password protected portals to see your data, but we'll conduct an in-depth overview of that process. So really excited about that. And also you can register via this link here, and we'll make sure we send this PowerPoint out in follow-up as well. And then we'll be having our last provider roundtable and CQI webinar of the year on December 8th. And so this will be kind of a second part of our initial session on the portal of October 6th, where we'll start to get into not only the data at a high level and where there are overall opportunities for quality improvement, but start to talk about what are some current strategies and processes that some providers have used in this space, and we're, as we speak, trying to reach out to some providers in terms of maybe presenting and discussing some of their strategies as well. So really excited about that. So please make sure you register and spread the word. So next we'll pivot over to open enrollment. So as I mentioned a few minutes ago, open enrollment just began back on September 7th. If you haven't heard from us already, you certainly will in the next coming days and weeks. And so what we wanted to do was provide some high-level tips that we found facilities and providers can benefit from. And so we'll go over these here just in the next couple of minutes. And so first is assigning one staff member to really serve as an Atlas champion. And so that is something that we've seen work very well in some facilities, as and when additional information might be needed from different individuals within a treatment facility. Having that one individual really serve as that Atlas champion can be helpful. And then in terms of who that person can be, and on many of our facilities, individuals such as a clinical or program director have been helpful in, again, serving as that central person that can help with this process. Secondly, circulating a reference copy of the treatment facility survey that was sent out just a few weeks back. If you have not received that, certainly let me know and we can make sure that we get that out to you. But if that's sent out to the relevant staff who are going to be part of the information gathering process, it's helpful for them to understand all of what is required, and they can get a feel for the type of information that we request during the open enrollment period. Time. So time is certainly required to complete the survey. So we found that depending on the size of the facility, the scope, the types of services that are provided, that the average time can range anywhere from just about 30 minutes to as much as 2.5 hours, with there being obviously a large time period in between. And so it's helpful for folks to kind of set aside the time to be able to complete the questions as well. Again, it's very much dependent on the specific facility in terms of the number of levels of care that are available, in terms of the size and scope as well. One thing that I will say, if you completed the survey in prior years, those responses will be pre-populated in the survey, and so we'll certainly save time for you as well. Next is scheduling time with the appropriate leadership. So as we all know, the survey requires a leadership attestation, typically from the CEO or similar leadership designee. So providing him or her with a heads up, or scheduling formal time so they can sign off and review the information as they need. Next is reviewing the data carefully before submitting. Obviously, goes without saying. We want to make sure that everything that we display is as you intended. But for any reason, if you once you submit the survey, if you do feel that there was something that you want to go back and adjust, you can certainly do that simply by submitting a request and emailing us at atlas@shadowproof.org during the data collection period. So you have until December 30th to let us know. So next slide here, there are more than just a few ways to get in touch with us. So we are here to help. So we have frequently asked questions that are linked here. So when you receive the PowerPoint follow-up, you can click on the link. It'll pull up some frequently asked questions. Secondly, you can email us, as I mentioned earlier, at atlas@shadowproof.org if you have any questions specifically on the survey or anything else. You can also submit a help desk ticket. So that's more of a formal way to submit a request. Our help desk team will get the ticket, log it, and someone from our team will get back in touch to help you with your questions. And lastly, and this is new this year, we have a helpline. So you see the number listed here below. It's 203-807-8313. And that is staffed 9 a.m. to 5 p.m. Eastern Standard Time, Monday through Friday. So you can also call if that is something that you find easier. So as I mentioned a few minutes ago, so we are actively conducting our open enrollment in 11 states. And so you can see the breakup of states listed here. So I'm working with Pennsylvania currently. My colleague Gina DeCipio is working with Massachusetts, West Virginia, and Delaware. My colleague Kelsey Knowles is in North Carolina. Michelle Magnum's in Florida. BK McDonough is working with New York. Patty Villaseñor is working with California. And Chad Williams is working with New Jersey, Oklahoma, and Louisiana. And actually, we are in the process of working with some additional states as we speak, but we are still going through final contracting, and so those announcements will come very, very shortly. So at this time, I want to just take a quick second and pause and see if folks have any questions regarding open enrollment. And I can stop sharing my screen for a moment here as well. So if you have any questions, please feel free to unmute yourself and we can help answer them.
I just have a quick question. Did you say the surveys were already sent out? Did I hear that correctly?
Yeah, thanks for that question, Maritza. So yeah, the survey links were sent out last week on the 7th. So if you have not received that email, please let us know and we'll make sure that we get that to you.
Okay, I don't think I received it, so that's why I was asking.
Okay, yeah, feel free to email our help desk, atlas@shadowproof.org, and someone will get in touch with you and make sure that you get that link.
Okay, thank you.
Yeah, no worries. Any other questions about either open enrollment or something more broadly about Atlas? All right, well, with that being said, then we can start to move forward with our agenda and get to our continuous quality improvement learning series webinar here. So let me reshare my screen. Excellent. All right. Well, again, if you think of any questions after our webinar here today, again, about open enrollment or anything else Atlas related, please don't hesitate to reach out either to our help desk or to your Atlas state director. Of course, we're always willing and happy to make sure you get the answer to your question. So as we move on to our continuous quality improvement learning series, so we'll be discussing a couple of things here today. And the first thing I wanted to go over was our patient experience toolkit. So this was mailed hard copy out earlier this month. And so I know with the Labor Day holiday, it may have taken an extra day or two, but your facility should have received a copy of the toolkit listed here that talks about our patient experience survey overview, talks about some strategies for increasing participation in the survey. There are some promotional materials as part of the toolkit as well, and then some final takeaways that talk about, again, the survey at a high level, and there's, I think, some answers to some commonly asked questions as well. Within that packet of material, each facility received a one-pager that you see listed here. And so this talks a little bit more about the patient experience survey. It has facility-specific information and also a QR code that you see here. So individuals, family members, patients can leverage or use the QR code either on their smartphone or tablet, and it takes them straight to the facility's patient experience survey. And typically, it can be completed in under 5 minutes. So if you have not received this, again, let us know. We'll be happy to follow up with you. If you have any questions about the patient experience survey itself or any of the content that you receive, again, let us know either at atlas@shadowproof.org or via your state director. So at this time, I have the pleasure of introducing our speaker here today, and I see that she joined just a few minutes ago, so welcome, Alice. So I'll turn it over to her in just a second, but just wanted to provide a little bit of background on Alice to the group here today. So Alice Dembner is a program director for substance use disorders and justice-involved populations at Community Catalyst, which is a leading nonprofit national health advocacy organization dedicated to advancing a movement for health, equity, and justice. Prior to joining Community Catalyst in 2008, Alice was an investigative and analytic journalist. During 30 years as an award-winning reporter and editor, she informed policymakers, influenced public opinion, and spurred change. And she holds a bachelor's degree from the university and graduated magna cum laude. So at this time, it is my pleasure to introduce Alice Dembner. Alice, welcome.
Thank you so much, and lovely to be with you this afternoon. I appreciate the opportunity to share some of our work with you. So let me go ahead here and share my screen. Mm-hmm. Okay, can you all see the slide now?
Yes, we can. Thanks, Alice.
Great, thank you very much. So thank you for the opportunity to share with you some work we did about prioritizing what matters to patients. Those of you who do not know Community Catalyst, I want to share a little bit about who we are, just to give you the context of this work. So as Angad said, that we're a national nonprofit health advocacy organization that's dedicated to advancing a movement for health equity and justice. And we partner with local, state, and national advocates across the country to build the power so all people can influence the decisions that affect their health. We also work closely with other stakeholders, including providers, health plans, and policymakers with the goal of improving our health system. And the program that I lead as the program director for substance use disorders and justice-involved populations works on advocacy to particularly improve services for people with problematic use of substances, particularly alcohol and drugs. So today I'm going to talk about a project that focuses on identifying the priority outcomes from treatment and services from the patient perspective. And what I'd like to do first is share a 7-minute video which features our National Peer Council in particular, talking about the project. And then I'll come back and tell you a few more details. And then we'll have time to discuss the findings and what they might mean for the Shadowproof Atlas initiative, as well as for your own facilities and practices. So would you show the video now, please? Thank you.
Will do. Yep. So Alice, I'm going to share my screen back so I can show the video. Do you mind to stop sharing for a moment?
Oh, I'm sorry.
Oh, you're fine.
Sometimes there's a novice on this thing, but let me stop share. There you go.
Perfect. Thank you.
Those of us who have walked addiction, we have traversed a path that has been full of a lot of darkness, pain, and suffering. To get to the other side of that means that we have a story to tell.
More than 20 million Americans have substance use disorders, and overdose deaths are continuing to rise. Programs and treatments aren't designed based on what matters to people with lived experience. So services aren't always responsive to individual needs, and many don't achieve the best results.
I'm a person in sustained recovery from a substance use disorder.
I'm a woman in long-term recovery.
I'm a person in long-term recovery from both a substance use disorder and a co-occurring mood disorder.
I am a person in long-term recovery.
The current model of treatment and recovery is essentially a treat and street model. An individual presents themselves with a substance use related emergency, they're treated for the emergency, and they're put right back on the street to repeat the cycle.
I've been to detox over 50 times.
With every other health condition, there's multiple different treatment options. And if you don't respond to the first one they give you, they don't say that there's something wrong with you. They say that's not the right treatment for you.
I was suffering and I couldn't figure out how to stop.
So often treatment has been deciding for individuals and patients what the outcome should look like.
The existing way is sort of like, all right, everybody come this way. We're all going through this door right here. And what if that door is not for me? Not for a lot of people like me.
We're at this turning point where we need to make a decision. How are we going to really help people?
How do we move to a place where we're asking patients now, what are the outcomes you want to have?
So that's what we did. Community Catalyst, with help from Faces and Voices of Recovery and the American Society of Addiction Medicine, conducted the first national study that asked people what matters to them. We engaged a group of 10 people in recovery to guide us, and we heard from nearly 900 others across the country through a survey and focus groups.
Voices from diverse communities were represented, not only ethnic and cultural diversity, also LGBTQ identities, and then geographic diversity as well.
But then we also had formal surveys that we sent out to figure out how could people get more of what they needed.
So often the system decides what success looks like. But this, I could tell from the start, was about helping us to define what success looks like for us and what health looks like for us, and empowering us to get there.
So much of the current treatment model by design has been supportive of a very white middle class. Addiction and substance use, it does not discriminate. It does not care about race or class or gender.
We asked people with substance use disorders, what are the outcomes that matter to you? Hundreds of people spoke up, and here's what we learned.
The very simple first response that seemed to be almost universal was just simply staying alive.
Enhanced quality of life, reducing harmful substance use, improving mental health,
Increased access to basic needs.
and then increasing that self-confidence, increasing those community supports.
Priority outcomes were also different across race and gender. For example, Black and Hispanic people in the survey prioritized taking care of basic needs more than white people. The report recommends ways to reshape the services, research, and policies that we need to better address the national epidemic of addiction.
There are more than 20 million Americans with a substance use disorder. We've interviewed just about 900. For as many people as there are in recovery, there are recovery solutions. So we need to continue the research.
We need researchers to find out what services best achieve the outcomes individuals want. And it's very important to look at differences by race, gender, to help make services better and more equitable.
Policymakers need to understand that a full continuum of services that includes everything from prevention to harm reduction to treatment services, recovery supports, the funding of that continuum of services needs to be robust across the board.
And when we talk about harm reduction services, we mean things like overdose prevention sites and programs, naloxone distribution, and syringe service programs that focus on keeping people alive.
For service providers, it will mean really working with patients, talking with patients, taking the time to actually understand what it is that is important for them within this framework of staying alive, increasing quality of life, and improving mental health and self-esteem. and reducing their substance use.
Everyone needs to come together to address inequities. That means policymakers, providers, community members all need to pull together. We need to provide effective service across cultures and languages, treat addiction as a public health issue, and address structural racism and discrimination.
What that means is that we really need to think about a treatment system that is integrated with addiction specialty treatment services, mental health treatment services, medical services, peer recovery support services, really making sure that people can have safe and supportive housing, employment, education.
We can save the next generation some of the heartache of addiction if we can invest in recovery now.
We have all the building blocks now. We really now can take the next steps that are so necessary.
I want to live in a world where we get to see a lot more of what recovery looks like.
To learn more, please visit communitycatalyst.org. Thank you so much. Let me get the. Okay. So as you saw in the video, we had participation from our great National Peer Council, which we were set up as part of the project. And I just want to reiterate one point of clarification here, that when I'm talking about substance use disorders in this presentation, I am talking about drugs and alcohol, not other substances. So let's dig in a little bit more. The official title of this project was Patients Lead, Identifying Meaningful Outcomes to Drive Substance Use Disorders Research and Care. And this was funded by the Patient-Centered Outcome Research Institute as one of their engagement projects. And as you heard, we've had some great partners with this, both the Faces and Voices of Recovery, which you may know engages 150 recovery community organizations and tens of thousands of people in recovery across the country, and the American Society of Addiction Medicine, their team from the Quality Improvement and Clinical Standards Division, and also a couple of ASAM members, including Dr. Ingrid Olsen, who was featured in the video and is now at SAMHSA heading up one of their centers. And so this was, in fact, surprisingly to us, the first national look at what treatment outcomes are prioritized by people with substance use disorders. And our long-term goal was to drive improvement in treatment services, and in particularly in the outcomes, by focusing on what people want and need. So going back to the project specifics, you heard a little bit about this in the video, but we focused on engagement of people with lived experience of substance use, either themselves or their family members. And we collected data using 3 methods. The first was the National Peer Council, which was representative as much as we could with 10 people of the diversity of the people across the country with substance use disorders. So by race, gender, ethnicity, age, socioeconomic status, geography, type of substance use, etc. And they really were at the core of the project, guiding every step of what we did. Secondly, we had an anonymous national online survey, which reached more than 800 people from 48 states. And that survey and a lot of the research was conducted during that first horrible year of COVID, when we were, all of us, trying to figure out how to live with this new terrible disease. Eligible survey respondents were at least 21 years old and had lived experience with substance use challenges, including addiction. There were a few family members who also participated in the survey, but most of it was individuals themselves who had that direct experience. We also supplemented the survey results with focus groups to dig a little deeper, and we had engaged 53 people, again, from across the country, different backgrounds, and they were conducted virtually, and they were asked, as were the survey recipients, about what outcomes from substance use treatment and recovery services were most important to them and why, which was also very important. And our participants in our project were compensated for their time. So what we learned, as again you heard in the video, but I'll show you again on the slide here, is that the outcomes that were most important to people were quite different from the priorities and current focus of much of our policy and practice in substance use disorders. The issue of abstinence was not a priority. Reducing harmful use was, but the top priorities were staying alive and improving quality of life. And things that, that I think we often think of as sort of the squishy other elements, right, were very much on their minds, about building self-confidence and self-efficacy and connecting people to services and supports over the long term. We did find these differences across race, ethnicity, and gender. And you heard about one of these on the video. The second one I'll talk about here, which is that in terms of transgender and non-binary recipients were much more focused on housing stability, when that really didn't rise to the top at all for other respondents. And the reason I think it's important to lift these up is that there is really a need for culturally effective services that meet people's individual needs and their intersecting identities. And we can't assume that one size is going to fit all. So some of the key takeaways were really to address the national epidemic of substance use disorders. We need to set aside our assumptions and focus on patient-driven solutions. And particularly that treatment and recovery is more than just stopping substance use, as many of you already know, and that people need increased access to the full range of comprehensive, culturally effective services that are individually tailored. And we believe that these priority outcomes provide a framework for reshaping treatment, research, and policy to focus more on survival and on improving people's lives. As you saw in the video, the project council and project staff, excuse me. There we go. Combine to think through what we could recommend on the basis of the findings we had and of the comments that people made both in the survey and the focus groups about the why and what was needed to achieve the outcomes that were identified as priorities. And so I think for service providers, the particular outcomes that rose to the top were the importance of clarifying each individual's desired outcomes by asking the individuals, and then offering multiple pathways forward to ensure that they can move towards those goals. Integrating mental health supports, even when there isn't already a mental health diagnosis. Providing harm reduction services, including syringe services, overdose prevention, and services that keep people alive so they can live another day to try to work on other things. And also using a culturally effective whole person approach tailored to the individual's identities. And finally, that all important connection to community and social supports to help sustain people in their recovery. And because so many people we know need more than just clinical treatment to get better. So we also address the issue of virtual services and discuss that, since that was front and center during those early days of COVID and continuing. And the recommendations were very strongly from the patients that virtual services need to be continued as an option beyond the end of the public health emergency, and that patients need to have the option of choosing either in-person or virtual services whenever possible, so they can choose what's going to work better for them. And then also for providers that need it, there should be training on active listening, on nonverbal cues, motivational interviewing, all to build that important connection with patients when there isn't a face-to-face contact. And then finally, that patients need to know what's out there. So they need to know, have a directory of services. And some of them will need training on how to access the virtual services, even now that many of us are experienced in that arena. We also made recommendations for research and policy change. And I've listed a few of the policy recommendations here that I thought were most relevant. And first is really that we need more funding across the board for that full continuum of services, and especially for things that tend to be last on the list for funding: peer recovery supports, recovery community organizations, community-based services, and harm reduction. We also need to be able to expand access to all forms of medication-assisted treatment and make permanent those temporary policies regarding telehealth and take-home doses that have been so important. And it's important also to ensure that insurance covers that full range of services so that we can get to those outcomes that patients are prioritizing, and we also need to take other steps to make treatment affordable. And finally, we need to really begin to work on those quality measures that are based on patient-identified outcomes. And I'm happy to say we've heard of some reports since we've published a study that are underway to try to do exactly that. And hopefully we'll begin building the framework for a new set of quality measures that we can all use that get at some of these. So I want to turn to connecting to the Atlas project that's gathered you all here today. And when we released a report, we thought about ways that we could use the findings to promote change, and Shatterproof's Atlas did come to mind. And as a minimum, we see that there's a potential for using the priority outcomes to help patients find care that meets their needs through the Atlas platform. And that could be through the assessment or through the patient experience study. The patient experience survey. But we'd like to hear your views. So I'd like to open this discussion part of the meeting and ask all of you, what do you think? Could these findings be useful for Atlas? And if so, how could that be? So would love to hear from you. I think I don't know what method you usually use for this kind of conversation. Those people can unmute themselves, or I guess put something in the chat, whichever is works better for you.
Yeah, thanks, Alice. So yeah, please feel free to either enter your question in the chat if you prefer, or you can unmute.
And I'm going to stop sharing my screen for just a moment, then we'll get back for the few more discussion questions as well, so we can all see each other. So the question is, how could these findings be useful for Atlas? Do any of the Atlas folks want to just throw out an idea that people might want to chew on? Oh, here we go. Okay, thank you, Madison. helping to assist with patient-centered care and engage people in treatment. Great. Other thoughts?
I think it's important what you guys are using to help the patient or the individual search out certain types of treatment, what they want to do. You know, like the video talked about, a lot of times, a lot of treatment centers always use this kind of one size fits all approach. And every time there's a change in the law or change in the state or whatever the case is, every treatment center just does the same thing and they all change, but in the same way. Where I think now we're starting to find more diverse options, you know, MAT centered, 12-step centered, you know, a PTSD and co-occurring centered. So if there's something in particular somebody really wants to focus on the most, hopefully there's a treatment center that that's their specialty or that's their strength. I think that's pretty important.
Thank you. Well stated. Other thoughts? So Lisa's commenting that the survey the experience survey is a very important part of Atlas, and the more individuals who submit information, the more information is going to be available, especially for those who may be members of marginalized communities. Thank you for that. And Jill is saying she's not sure about Atlas, but as an addiction clinician and recovery coach, she sees many people are seeking moderation versus abstinence because abstinence seems unthinkable. And I think that's absolutely true. And that's what we heard again. Maybe I'll get there, but if I focus on that as a start, I'm not going to even start. So very important, I think, to be clear about that. That's an option for people.
I appreciated the fact that you really looked at diverse populations, BIPOC communities, to lay out that needs to be understood more deeply in order for treatments, no matter what the breadth is, could be much more successful. Without taking that into account, it really is doing a disservice for the patient. Absolutely. Yeah, when we expected to find some differences, but we didn't know what they would be. And yeah, it was very important to see those. And that's an area where more research is also needed. And we're doing some of that work, and so are others at this point, to look more deeply into that question.
Yeah, and I would just add maybe as we continue to iterate on Atlas, at some point in the future, start to think about more how we can incorporate the feedback that we're getting from patients and link that to specific facilities in terms of based on what we've heard, how can that impact some of the treatment modalities to help support in this case, as Jill mentioned, right, if there is this interest in seeking moderation, right, well, where in a specific facility is that part of their treatment.
Thank you. Well, let's go on to the next question. Whoops, oh, here we go. Yes, okay. So how could these findings influence the way you provide treatment and services, as opposed to what Atlas can do? What do you think about what you're doing, and what would this affect in any way the way you operate? And a few of you, I think, have begun to address that, but I wondered if there are additional thoughts. And there's no right or wrong answers here, but just we're always interested in hearing how people relate to this study and what people find to take home. So again, how could these findings influence the way you provide treatment services? And again, I'm going to stop sharing my screen so we can see each other if people want to come on camera and speak. Are people asking these questions in your, or are you or other providers in your facilities asking these kinds of questions of patients on a routine basis about what are they, what do they want out of treatment? What are their goals? What are their needs?
Yeah, I was just gonna say the same thing she did. For treatment planning, we always focus on, what the client wants and how to achieve best, their particular goal. The other thing I really found that's important is making sure that our staff, at least what we do, our staff is very well versed in what else is around us as far as community resources. As an example, like we're not a MAT provider, but if somebody calls and they're looking for that, we don't just say, we don't do that here. We have a list of options for them in their area with the insurances they take. We try to make sure that even if we can't take a client, we get them to the best place possible in their area, I think is very important as well.
Sounds like great best practices. Thank you. And I see Marcia has posted that they do a survey twice a year with patients, and a separate survey that includes the staff in regard to treatment and the services that they provide. Could you clarify a little bit, Marcia, either in chat or in person, what the second survey is?
Well, we do a survey with our staff in regards to, I'm not going to say just competence with working with patients, but to get their opinion on the services we provide and how we provide it, their experiences with their caseloads, even that includes the front end staff, receptionist, nursing. We do surveys in addition to our team meetings and what have you, but we also have a PAC committee, which is our patient advocacy committee, that I actually facilitate with members, patients who are involved in the committee. What we do is we discuss suggestions that are placed in our suggestion box, as well as we have a patient advocate that patients can call this person who's also on the committee to voice any concerns or issues or suggestions, and that particular patient advocate would attend our administrative meeting to further, I guess, discuss what I would bring to the administrative team, but we have the advocate also participate in order to basically speak up for the patients and what their concerns.
Great. That's wonderful. And that does that staff survey get at the question of what are they hearing from and what are they feeling about how their ability to help patients achieve their goals and get the outcomes they want?
Absolutely.
Important. Great. Do you have good participation in your patient survey?
Yes, initially we've been doing it every year I've been at the job 20 years, so we've always done a survey. They've become more streamlined in regards to the patient survey. We also have a consultant who comes in and we take a look at the statistics of the survey based off of There are closed-ended questions as well as open-ended to basically get the opinion of the needs of our patients.
Sounds very thorough. Thank you so much for sharing all of that. And I see Madison posted to say that they try to assist the client where they are in their recovery, wherever that might be. Very, very important also to do that. Great to hear all this promising practices. Other thoughts, other people who are already using similar things to this, what we found in the survey, or thinking about what else they might do. One of the things we were really struck by in the study, and obviously it was conducted in the midst of COVID, so that may be a factor in it, but that the fact that staying alive was really the top desired outcome. I wondered how many of you really are focusing in on that as a primary objective in your work. I don't know what to make of the silence. Is that a no-brainer question? Is that something you automatically do? So Jill is saying she wonders whether the state of mental clarity, she wonders about the state of mental clarity as the surveyors filled this out. Staying alive feels like a desperate answer. That's an interesting question, Jill. This was a voluntary survey, and people certainly were could have been in all stages of their recovery. We did ask people to share that. Some people shared the demographic information, some didn't. That was not required. And that included, and demographic and treatment sort of status questions. We have Maritza saying it hasn't come up a lot with the clients she worked with, but though she does say many of them want to reconnect with family. Certainly connection to community and connection to services was important in the survey as well. What was interesting to me, and answered sort of response to your comment, Jill, was that among our National Patient Council or National Peer Council members, that staying alive, who were most of whom were very far into the recovery, that was a priority for them as well. And that even those who were, seemed to be in secure jobs and, as it's well advanced in their recovery, were very concerned about that, continually concerned about that, and about, sort of that possibility with a disease that's marked by recurrence, right? That there could be, a moment when there would be some challenges in that arena. That was front and center for them as well. And we asked about COVID, was it just, did they think this was just because of COVID? And obviously it's always hard to take yourself out of a situation once you're in it. But they said no, that was really just sort of the core issue always for them. So I think there's something there that we need to, continue to think through about what that means, and how do we prioritize, make sure we're prioritizing that when that's a patient goal.
I don't know if I think this may kind of have to do with that answer. One of the things that we try to do here, and again, this is just our own little niche, you know what I mean? Where we talk a lot about, even in like the 12-step arena, where there's a lot of like fear-based recovery, like what will happen if, and there's always these ifs in people's recovery. And we try to change that mindset through like, you know, MI and CBT and just even the 12-step process of like turning that fear into faith. Like instead of the fear of relapse, it's the faith that we won't. And how just that mindset tends to keep people in a more positive idea and a positive path, as opposed to questioning their own decisions and that kind of stuff. So a little bit of a mindset there as far as like staying alive goes. Not trying to take the focus off of that process, but it's almost trying to remove that fear. So they're not always in fear when making a decision.
Mhm. Thank you for sharing that, Brian. And Maritza's added that that stability has also come up with the patient goals in her facility. And forgive me if I'm making assumptions about gendering from the names, and if I've misgendered anyone, I apologize. So Madison is saying that they've only seen that in one patient a report of priority of survival, and that was right after a friend had passed away from an overdose. So that's clear that why there was a reason for that too. Yeah, absolutely. Well, I had one more question that I wanted to ask you. So let me get to that. So what needs to happen in order for providers who aren't acting on these recommendations to act on them? What are the barriers? What are the challenges that you and your colleagues are facing that get in the way? And the reason I'm asking this question is because as a group of advocates, the organization I work at is 100 people strong that is working. And one of our key things is to knock down the barriers that are in the way of progress so that we can all move forward, because we know there's also often we know what needs to be done, and we want to go there, but we have, you know, lots of other expediencies in our professional lives that may get in the way, or and you know, things that are out of our control. So what else do you think needs to happen for you or for your colleagues or for the field in order for more people to really focus in on what the outcomes the patients really want, and some of the other recommendations that came out of this work?
I'd like to say that sometimes our patients or even our providers, they really need somebody to advocate for them, whether it's with the pharmacy, whether it's with the insurance company, whatever, you know, even a landlord, you know, whatever, in electric, whatever exactly it may be at that particular time, but actually reaching out to those people and just saying, like, you know, this is a crisis of whatever kind, you know, going on, that this person is in active recovery and inactive treatment of whatever kind, you know, that they're at right then, and just making sure that they're safe. Like, it really shocks me. I think sometimes that some providers that I've had a interaction with, there's a disconnect, like that not everybody is in this for the same reason. And that's really sad, that, you know, that there are some people that are in this that don't have the want to, like the rest of us that are on this call today, that, you know, really want the best for our clients and our patients, and to help them in whatever way, shape, or form that may be.
Mm-hmm. Absolutely. Thank you for sharing that. And I do want to make a comment, which I assume it probably won't, you know, will resonate potentially with the providers here, but but there are certainly other providers who might not. But we know we've seen an explosion of caregivers, professional caregivers during this, and facilities during this period of the explosion of substance use disorders, and particularly opioid use disorders. And yeah, a lot of them come in with good hearts and good intentions. And there are always some others who don't in any field, right? And who are chasing the money and the opportunity. I'm not going to cast stones at anybody in particular, but I think, we have to be aware that's unfortunately part of our society. Important to try to sort that out. And I think Atlas is great, and I think an important tool for patients to help them find the ones that are going to do the best. So appreciate you're all engaging with it. And Shatterproof didn't pay me to say that.
I just wanted to add, I agree with Madison, but I also wanted to add that, part of the barriers is a mixture of what I've seen is people that are making the decisions that are not hearing out the clients that we work with or the patients that we work with. They're making decisions when they haven't even been, at the programs working and seeing, what's happening day in and day out. And I think it's important to hear from a patient's point of view what their needs are, because they're the best, person that can, share that. I think another barrier too, what I've seen with at least my staff, I have some staff that have been in the field for quite a long time. And so they're kind of stuck with the way things used to happen in the field versus now. And so, trying to get everybody on board with that as well. Like, there is such thing as harm reduction, and we're going that way. Like, I noticed some staff have struggled with that, or I have some staff that are in recovery and they feel like, methadone maintenance is not, a good option. And so I think, just kind of getting everybody on board and educating them. And also the people that don't understand addiction, period. They just don't get, that it is a disease and what comes with it and all of that. So I think there's quite a few barriers. So I just kind of wanted to mention that.
Thank you. And you're getting some response from your colleagues as well. That's hard to get staff on board sometimes. And yeah, we all get stuck in our habits, right? Very easy it's a human thing to have happen. But we also have amazing ability to change and to learn new things. So let's try to find that way forward. And I don't know if it would be helpful for you, but I'll show you this in the last slide, and you'll get a copy of the slides to after the presentation. But there's a link to the video, and it's for example, any of your staff or staff of colleagues to watch the video to hear from people themselves. Sometimes that's helpful in moving people, the stories more than the facts. So that link is a publicly available link. So please go ahead and do that if that makes sense. Any other thoughts on this question about barriers?
I'll say something just to get some conversation going again.
Okay.
First of all, this has just been fascinating. So thank you, Alice. And thank you to Shatterproof for doing this. So barriers, I mean, this is like the elephant in the rooms, which is why I think we're all like not saying anything because it's such a big nut. But I'm just going to circle back. I mean, I myself am in recovery, and then I've been spending the last 6 years. I'm also a nurse, and so certified mental health, psychiatric mental health nurse, as well as then I went ahead and was board certified for recovery coaching. So I've And that was helping me actually with my recovery, although that's not exactly why I did it. But I will tell you at this point, while I'm an expert with alcohol use disorder, substance use disorder, something I'm trying to focus on more of. And I just feel that when someone is in need of help, I just feel like they're the last person at the moment of day one to say what they really need. Because everyone says they want to figure out how to keep living with their substance. Like they just, so our job as treatment providers or coaches or counselors is to help try to remove them from the substance for at least a period of time to achieve some sort of mental clarity and vision about creating a life moving forward. I mean, so just punting to moderation is, I understand why it's happening, but I just question it. Like, are we really doing people a service? I think that was said like 10 minutes ago. Like, how beneficial is that really? So the barrier to me is just the confusion on day one of all the players, both the person who's having the addiction and the entire family around them who have at that point had it. Like, they're confused, they need help, everyone is in a crisis. And so to rally around moderation, and spend money and resources to help someone continue drinking or using, I just really question that. So I don't know if that is helping this conversation, but to me, a barrier is just clarity and the reality of what addiction is and isn't.
I appreciate your sharing that, Jill, and would love to hear what others' response to that is.
So I've been in the field for about 12 years, been sober myself for about 15. And I get that thought process 100%, and as a person who does himself an abstinence-based 12-step program, I felt like that for a long time. And then ultimately, I think what happened to me for being in the field for so long is too many funerals. To be honest, that abstinence base, that clarity that you're talking about, it definitely worked for me, for sure. I think offering multiple pathways, and not even so much in your own facility. I'm a pretty big proponent myself in allowing treatment centers to do what they do best, like we were talking about. We're small, we can't be a one size fits all. And I think sometimes that does a client a disservice. So if I can offer them a 12-step spiritual based treatment center here, and my friends at Discovery House up that's right down the road that has the methadone, and my friends at the South Hills Recovery Center have the Suboxone, whatever the case is, as a team, as a group of providers, we can come up with the best plan for each individual person. But yeah, I totally understand that as an absence-based person myself. And I struggled with that for a long time. So we just try to help the clients that we know want that absence-based, want that type of recovery, and try to get the other ones to places that fit what they're looking for as best we can.
Do others want to join this conversation? I think it's important to talk to this, and as Jill said, it is the elephant in the room. I know, I a family member with addiction issues, and they come at this from different perspectives themselves. So I think that's, to me, that it's the multiple pathways is important, because there are people who are able to moderate and their addiction somehow is different. I mean, or maybe they're not, you know, fully down the pathway to addiction, though it certainly seemed like it from their behavior. But they are able to moderate and to do that. And I don't know that that's a disservice to them to help them to do that, if they're able to do that. But I think it's a complicated illness, right? And we still are learning about it.
I just wanted to share, first off, Brian, I loved everything you said, but that I think in a broader sense of this question, right? And I think it also goes over into the mental health field as well. There's often a temptation for folks working in behavioral health to be working with someone and feel that they see the challenges so clearly that if the person would only do, you know, what we were asking them to do, like surely everything would work out and it would be fine. And it can really be frustrating and lead to burnout when folks sort of have their own ideas about, you know, what they'd like to do, their own priorities. But I've found that when I get in that sort of place, I have to sort of pull back and realize that like my experience and preferences and what works for me is very specific to me. And I can't assume that that same path will work for another. And I've found that by sort of following where the person leads, even if it's in a direction that I, you know, when I was working as a provider, didn't feel would do them the most good, that if nothing else, I improve that rapport, that relationship, and I leave the door open for further work in the future. And I'll share just a super brief anecdote because I think it's really powerful and hopefully it'll make you smile. But a colleague of mine was working, providing peer support to a gentleman who had significant mental health challenges, so significant that he lived on disability and sort of needed to live in like a group home situation. So he's working with this gentleman and he's like asking him, what are your goals? And the man says, I want to be an astronaut. So, you know, you can imagine the position of the peer provider thinking like, listen, you know, you're living on disability, but he didn't do any of that. He said, okay, what would be the first step of becoming an astronaut? And the gentleman said, well, I guess I should learn about space. And they said, great. How do we learn about space? So they started meeting at the library once a week and like looking at books about space. So where that ended was the gentleman decided, hey, I actually really like the library. I like being here, and decided I don't want to be an astronaut after all. I think I'm going to get a job at the library. And he ended up getting like a part-time job at the library that made him really happy. But if that peer provider hadn't sort of followed that road where it led, right? Like we wouldn't have gotten there. So I just love that example. It's always really stuck out in my mind as such a clear shot of if you kind of follow someone where they lead, not only do you create this really cool, strong relationship, but you might get to a destination that you didn't realize you could get to, if that makes sense.
Definitely. Thank you, Kelsey, for sharing that. It's a great anecdote to connect with. Well, I feel like this we've opened up a wonderful conversation here, but I'm also conscious of your time and us nearing the end of our time together. So I'm going to return just for a moment to my slide deck to give you this, show you the slide with my information and the links to the aspects of this report. And feel free to reach out to me. Let me do that. And if you want to continue the conversation, also obviously the Shatterproof folks can offer and other opportunities for you to discuss this and other things. So again, to thank you for the opportunity to talk with you. I'm Alice Dembner, and you can reach me at ademner@communitycatalyst.org. And the full report, which is about 40 pages on what we did and what we found, is available online, as well as a shorter 2-page summary. And as I said, the link to the video there. So feel free to point anybody in the direction of those materials. And I appreciate so much the opportunity to meet with you today and to share this. And I look forward to hearing from any of you if you have thoughts, and wish you good luck with continuing on with the Atlas project. And thank you, Shatterproof, for the opportunity to present today.
Great. Thank you, Alice. And thank you all for attending today. I know everyone has busy schedules, so appreciate you carving out some time. While we do have 5 minutes left, are there any last minute questions for either Alice regarding the great work that her organization, Community Catalyst, is doing, or for the Shatterproof team? Please let us know. I'll keep the line open for another minute or two. Feel free to, again, put it in the chat or unmute. Otherwise, again, thank you for attending, and I hope you have a good rest of your day.